My name is Dr. Ashwani Ranjan. I have done my MD in Preventive and Social Medicine from AIIMS New Delhi. And today we are going to discuss questions that had been asked in NEET 2018 PSM. Okay, these questions are important not only because they cover the topics that are going to come in your forthcoming examination, but also because in these questions, while solving this question, you will learn the concepts behind p-value, concept behind attributable risk and population attributable risk, difference between relative risk, odds ratios, and various important questions that will clear your concepts as well regarding difficult topics of PSM. Okay, so let's start our discussion with the very first question, that is, which of the following test of tuberculosis diagnosis is done by taking whole blood sample? Okay, options are gene expert, backtick, fluorescent microscopy, and IGRA. Okay, so recently the RNTCP, that is Revised National Tuberculosis Control Program, have underwent various changes, and these changes are being asked repeatedly in several examinations. So we are going to understand about all those new changes in these three questions. First is test for TB diagnosis by taking whole blood sample. Okay, so for that answer we have to know about all the options in detail. First, let's go through all the options one by one. Let's first read about this IGRA. What is this IGRA? IGRA is interferon gamma release assay, and it is the only test among these four which take whole blood sample for diagnosis. Okay, so the answer for this is D. But let's know all this question one by one in detail. What is interferon gamma release assay? In interferon gamma release assay, we take the whole blood sample, like the one that they are showing over here. Here they are taking the whole blood sample. Then in this whole blood sample, if the patient is infected, there will be some antibodies. Okay, so what we do is we make an antigen and T cell complex. What? Antigen and T cell complex. And in that antigen and T cell complex, we mix the blood from the patient. Okay, so if the patient blood is having antibodies, it will react with antigen, and on reacting with antigen, it will produce interferon gamma. Why? Because interferon gamma is a cytokine, is an inflammatory mediator. If there is an antigen antibody reaction, interferon gamma will lead to attract further immunoglobulin G and cytokine for that reaction. So interferon gamma is a chemical mediator of an inflammation, and hence it is released when a patient blood having antibodies react with antigen and T cell complex that is already present in the lab. So what happen in IGRA test? Patient blood sample is taken to detect whether there are antibodies of TB present in the blood of patient or not, and then this sample is mixed with antigen T cell complex that is already present in the lab. On reaction, interferon gamma is released, and this interferon gamma is then quantified to know about presence or absence of antibodies. This is interferon gamma release assay. Okay, now why we are using this interferon gamma release assay? One is to know whether the patient is having TB or not. So before this interferon gamma release assay, that means previously we used to do tuberculin test to detect whether the patient is infected with TB or not. But that tuberculin test were having several limitations. What were the limitations? You all must be knowing that tuberculin test, first thing is tuberculin test give various false positive and false negative. But interferon gamma release assay does not give any false positive or false negative. Okay, Let's look at the difference between interferon gamma release assay and tuberculin test in this. Okay. What is TST? This TST is tuberculin sensitivity test. Tuberculin sensitivity test. How it is done? In your ulnar part of forearm, that is this part or this part, you inject PPT, that is purified protein derivative, PPT, purified protein tuberculin derivative, PPD, twin 80 PPD in your upper forearm, this forearm region, and then after 72 hours, you examine for the spread of that tuberculin infection in your arm. Okay. And if that spread is more than 9 mm, okay, then it is considered to be suggestive of having tuberculosis. But if it is less than 5 mm, then it is suggestive of not having tuberculosis. Okay. So in tuberculin sensitivity test, we examine after 72 hours. That is almost about after 3 days. Okay. But here the result comes within 1 day. What is the second difference? The second difference is if there is BCG vaccine, that is Bacillus calmette guerin vaccine, which is given to newborn, if it has been given, then they show positive. In tuberculin sensitivity test, they appear as positive. But in interferon gamma release assay, even if the child is given BCG, he will not be positive on test. The test will be negative. Okay. The second is in an immunosuppressed individual, like patient having HIV or severe TB, there will the spread will be less than 5 mm, and hence it will be a negative. But he might be having TB, but if he is having TB along with HIV, then because of HIV, his antibody reactions are very less, and he will be false negative, because actually he is having both TB and HIV, but because of HIV his antibodies level are very less, and tuberculin sensitivity test will not be able to detect that. Hence he will be false negative, but no such false negative will come in IGRA. It is very rare to have any false negative in immunofluorescent interferon gamma release assay. Okay. The second is the result assessment or interpretation is done by a computer, so it is more reliable, and assessment is done by a health practitioner, which is susceptible to error. So the better is interferon gamma release assay. Now you understand what is interferon gamma release assay. Interferon gamma release assay is a test which replaces tuberculin sensitivity test, and it gives very less false positive and false negative result, and it is not affected by previous BCG vaccine that is given to the child. Okay. So now we use interferon gamma release assay in place of tuberculin sensitivity test. Now what is Gene Expert? Gene Expert is the new test which is recommended under RNTCP guideline. Gene Expert is also known by one more name, that is CBNAT. What is CBNAT? You must be knowing it. CBNAT is cartridge based nucleic acid amplification test. Okay. Nucleic acid amplification test. Okay. Amplification test. What you do in that, in Gene Expert or in CBNAT, we use the technique of PCR. What is PCR? PCR is polymerase chain reaction. Polymerase chain reaction. By using this technique, we detect the specific sequence on which tuberculin antibodies are formed, and whether the drug resistance is present or not, and with help of that specific DNA sequence we will be able to tell about resistance in TB or presence or absence of TB with a very good precision, Okay. So even if sample is with low bacterial load, like in children or in HIV positive person, CB net will be positive. Okay. Second is, it uses polymerase chain reaction, as I told you, for rapid for rapid diagnosis of tuberculosis bacteria and to detect resistance to rifampicin. Okay. So the result comes out in less than 2 hours. Okay. So it helps. It also helps in detecting MDR TB and resistance to rifampicin. It is superior to smear microscopy, which we used to do by ZN staining. We used to do AFB testing with help of Gill-Nansen staining technique. So it is better than ZN staining technique. Why? Because it can detect sequences of DNA. Okay, and it is computerized, so there are again less chances of human error. Okay. And gene expert facility is going to be extended all over India according to revised RNTCP guideline. Okay. Now, what is backtech test? That was the third option. So the backtech test is a replacement to the culture. Previously you used to do culture, but now what we do? Backtech test. Why? Because backtech test give the result within 10 to 12 days, whereas culture gives the result by 14 to 21 days, mostly by 21 days. Okay. Second is, backtech test detect the CO2 produced and the reduction in O2, and hence it is biologically detected by this machine. And again, there is automated reading done by computer, so there are less chances of error. And it can hold 960 patient sample at one time rather than the culture, which is done for individual patient. So it's better than culture because of three things. One is because it is automated. Second is because it can detect 960 sample once at one time. And third is because it takes only 10 to 12 days. Now the fourth is fluorescent microscopy. Fluorescent microscopy is done again as a replacement to smear microscopy, ZN smear microscopy, है ना? And it is better. Why it is better? Because staining is done with help of auramine O, and it is having higher sensitivity than light microscopy. Okay. But the specificity is almost equal, and it requires a dark room for examination, and this device is very costly. So fluorescent microscopy is rarely present at most of the places, but CB net or gene expert is the new diagnostic procedure which is going to be available at almost all the district tuberculosis unit center in forthcoming year under revised national tuberculosis guideline. Okay. Now let's go to the second question. So you understand what is gene expert? Gene expert is CBNet. These all three tests, they require drop of blood. Okay. And it is done by taking whole blood sample, which you can also see in this diagram. Okay. Now let's move to our second question, which was again based on TB. The question was, most peripheral TB unit is called. Some student also say that the question was regarding most peripheral TB unit having facility of microscopy. In both the cases, the answer is microscopic center among these four options. Okay, because designated microscopic center, DMC, designated microscopic center is the most peripheral unit. Okay, it is the most peripheral unit. Okay, let's see it in this hierarchical diagram of TB, structure of RNTCP. The first unit, that is central TB division, the uppermost unit, and DGHS stands for Director General of Health Services. and Director General of Health Services regulate this TB division. They give this their directions to state TB cell. State TB cell have a state tuberculosis officer. Then the direction goes to district TB center, where they have district tuberculosis officer. Then to tuberculosis unit. Previously, it was on 2.5 lakh or 5 lakh, but now in revised RNTCP guideline, it is at 1.5 lakh population. That means number of tuberculosis unit have been significantly increased in revised RNTCP guideline. Okay. So then tuberculosis unit takes information from 5 designated microscopic center, and this designated microscopy center is the most peripheral center where microscope is available. Dot center is again one of the peripheral center, but here no microscope is available and only drugs is being given by some of the dot provider or community worker. So the most peripheral unit where microscope is available is designated microscopy center. Dot center can be the most peripheral unit, but it was not in the option. So if in the option most peripheral TB unit is asked, the answers can be dot center, but not E dot center. Okay. But if the question is most peripheral TB unit having facility of microscopy is asked, then the answer will be designated microscopy center or DMC. Okay, having facility of microscope, then DMC. Most peripheral TB unit is dot center. Clear? If they ask most peripheral TB unit, the answer will be dot center. If they asked most peripheral only dot center, not E dot center, then if they ask most peripheral TB unit having facility of microscopy, the answer will be designated microscopy center, DMC. Okay. Now let's move to third question. TB program in India is called. Let's understand. Answer is, you all know, NextCare. What is NextCare? NextCare was launched in May 2012, and it was May 2012, and it was case-based, web-based application. What does it mean? It means case-based mean every case, every individual patient is web-based, is reported online, reported and followed online. Okay. So every individual patient is reported online in NextCare portal. What is NextCare portal? NextCare portal is a website developed by Government of India to be used in RNTCP program, in which all the government practitioner as well as private practitioner will send patient individual report to the higher center. That means previously what used to happen is only government doctors used to provide data regarding tuberculosis patient, and since most of the patient goes to private care provider in India, so the data regarding their treatment or regarding their failure or loss to follow up was not used to come to Government of India. So to improve this irregulation, or to improve this process of reporting and to include the private care provider as well in the reporting system, Government of India launched NextCare, in which the TB notification is done using mobile app, either through hard copy or through soft copy using login ID. That is hard copy, email, soft copy, and data entry operator enters it in NextCare. DEO stands for data entry operator, and there is a data entry operator at NextCare center in district, and it enters the data, and this data from district goes to state, from state it goes to central TB division, and every individual patient is looked out for completion of treatment. Okay. Now the second is NISCHA. What is NISCHA? NISCHA is a kit to detect pregnancy, and it is used by ASA. Okay, this is NISCHA kit. Okay, in NISCHA what they do is the rapid one-stop HCG urine pregnancy test card. HCG is, you all know, is human chorionic gonadotropin. Chorionic gonadotropin is a hormone which is secreted by, HCG is secreted by, first it is mostly secreted by the placenta, but in the initial phase this is also secreted by the corpus luteum, which remain for some time after conception. So HCG hormone is secreted from corpus luteum and then from placenta. This hormone is detected by rapid test kit, in which one drop of urine is taken, and rapid test kit detect either pregnancy present or pregnancy absent. Okay, if there are two lines, it shows that the patient urine contain HCG and hence the patient is pregnant or having tumor of, but mostly it suggests pregnancy. Okay, so Nishchay is the kit used by ASA to detect pregnancy at an earlier level. Earlier level, that means less before 12 week. Okay, that is known as early registration. Early registration means writing the name of patient in the register given to ASA worker before 12 week is known as early registration, and this is done by ASA with the help of Nishchay kit, because Nishchay kit help in detecting pregnancy before performing ultrasound. If you have one miss period, you go to ASA, you ask for Nishchay kit, and that Nishchay kit will help you in detecting whether you are pregnant or not. Okay, now look, going on to E-dots is not anything. It is, E-dots is nothing. It's just a random word which is used as an option, but 99 dots stands for one thing. This is 99 dots. What is 99 dot? 99 dots is the newer method adopted under RNTCP through which compliance can be checked. Compliance to drug can be checked. How it can be checked? What happen is, every patient get this kit. This is the drug kit. Okay, in this drug kit, after removing 2 tablet, after eating 2 tablet, you get a secret number. Okay, then this secret number is sent to you, to your dot provider. Send to dot provider, and then dot provider get this message and come to know that you are taking the drug regularly. If this message does not come to dot provider, he will come to you and inquire what are the reason why you are not taking the tablet. Okay, so this is a newer method under RNTCP used to assure compliance to drug, used to check whether the patient is taking the drug regularly or not. Okay, so let's move to our third question. But before moving to our third question, let us also discuss some of the newer changes in RNTCP guideline. Okay, in RNTCP guideline, because these questions are going to come again and again. First thing is, previously there used to be 2 categories. Now there is category 1 and category 2. Now there is no category 1 or category 2. Okay, now the two cases are only, the cases are of only 2 types, either new case either new case or relapse, failure. Failure is not used anymore. We use the term loss to follow up. Loss to follow up. Okay, or resistance. These loss to follow-up or relapse. These all cases are in second category, but they are not named as category 2. There are 2 categories still, but they are not named or classified under category 1 or 2. What is the second change? This is the first change. What is the second change? The second change is on the duration of treatment. Previously, category 1 used to get 6 months of treatment, 2 months of intensive phase and 4 months of continuation phase. But now it has changed. Let me write you about the duration of treatment. Duration of treatment in week. This is duration of treatment. ठीक है. First is intensive phase. Intensive phase. And second phase is continuation phase. Why intensive phase and continuation phase? Because in intensive phase you give more number of drug. Okay. In continuation phase you give lesser number of drug. During intensive phase you need to give intensive treatment to stop the multiplication of tubercular bacilli rapidly. That's why you give more number of drug in intensive phase. So what is the duration of intensive phase under category 1? It is, yes, it is 8 week. Okay. And what is the duration of continuation phase? It is 16 week. Okay. So total 8 plus 16 week. Total कितना होगा? 8 plus 16 will be 24 week. Okay. Okay. Under category 2, it is 12 week intensive phase and 20 week continuation phase. So a total of 32 week. Okay. Total of 32 week. Now it's not very difficult to remember. You just have to remember 8 and 16, 8 and 16, 8 का double है 16, and then you have to add plus 4 in both numerator and denominator. Then you will get duration for category 2. So you need not to mug up, just remember this simple thing, that 8 week is the intensive phase, because previously it was used to be 2 month. So 2 month is almost equal to 8 week. So it has remained the same. Now 8 का double होता है 16 week, and that will be the duration of continuation phase under new case. That will be no category 1, new case, and this will be this category 1 and category 2 is no more use. New case and relapse or loss to follow up will be category 2, है ना? So in this category 2 you will have 12 week of intensive phase and then 20 week of continuation phase. Just by adding plus 4 you can get this 12 week and 20. Total is 32 week, total is 24 week. Okay. What are the other changes? The third changes is, previously after end of intensive phase, end of second month or end of intensive phase, you used to take the sputum sample, and the sputum sample if the sputum sample comes out to be positive, you used to give 1 more month of intensive phase treatment. Okay, ठीक है? So previously after end of intensive phase, the sputum testing was done, but now sputum testing can be done at any time. Okay, can be done at any time based on observation by the physician. Okay, based on physician decision, and no prolongation of intensive phase. Even if the sputum sample is positive after 2 months of treatment, you do not continue the intensive phase for 1 more month. So there is no prolongation of intensive phase. Okay, which was done previously. The fourth is a new drug, that is bedaquiline, which is used for treatment of Yes, MDR-TB is a new thing. Okay, MDR-TB. इसके ट्रीटमेंट के लिए न्यू ड्रग यूज की है बेडाक्विलिन. इट हैज अ वेरी हाई एंटी बैक्टीरियोसाइडल इफेक्ट, so it decreases the tuberculosis bacteria count very rapidly. The fifth thing is daily treatment. Previously we used to give treatment 3 days in a week, but now daily treatment is given in place of 3 days treatment in a week. Okay, so these are the 5 changes which you must have to remember along with these 3 questions which I discussed. Now let's move to our fourth question, which is adult form of echinococcus is found in. Okay, echinococcus is a cystic disease, echinococcus granulosus, and in echinococcus the adult form is present in dog. Okay, this you must be knowing, but let's look at the life cycle of echinococcus granulosus. What happens is in the adult, that is the definitive host, adult is present in the small intestine. Okay, and then in the sheep or in human, both are the intermediate host. Okay, in this intermediate host, a mature form, hydrated cyst is present. Hydrated cyst is present either in liver, lung, or etc. What are the etc.? Hydrated cyst may present at lung, may present at brain, may present at heart, may present at spleen, may present at liver. So at all these places hydrated cyst may go. And how these hydrated cysts reach over there? The thing is, if embryonated egg is present in the feces of a dog, and if by any way we touch the soil having this embryonated egg, having feces of dog, then this egg enter to our intestine, and from here it reaches to the blood circulation through heart, and then it can go to all of this part, which is indicated by 4. So the answer is adult form is present in a small intestine of dog. Okay, but there was one more term which you need to know, is definitive host and intermediate host. Definitive host and intermediate, because many a time regarding various diseases this concept is being asked, that which of the following is intermediate host or which of the following is definitive host. A definitive host is one in which parasite or pathogen जो भी है, parasite or bacteria or protozoa, anything which can be, it divides or underwent reproduction. Okay, and in intermediate host it can grow in size, it can multiply, but no reproduction. Okay, if there is reproduction, then the host inside the body of host, then the host will be definitive host. If there will be no reproduction, then the host will be known as intermediate host. Clear? So in this case again, the dog is both the definitive host, and in the dog the adult form is present. Okay, so now let's move to our another question. Which of the following is vector for transmission of disease shown in the following peripheral blood smear? So first we will have to look at the peripheral blood smear. This is the peripheral blood smear. What is the characteristic feature which you are seeing in this peripheral blood smear? This is what this characteristic feature is known as. This is known as Maltese cross. Maltese cross, and it is present in a disease known as babesiosis. What happened in babesiosis? In babesiosis, this parasite enters in body of a tick, and that tick transmit it to human being or to dog, and if it comes to human being, then it leads to hemolytic anemia. Okay, and the characteristic features of babesiosis will be similar to malaria. There will be fever, there will be vomiting, there will be hemolytic anemia. So to distinguish between malaria and babesiosis, we do a peripheral smear, and if in peripheral smear there is Maltese cross, then it suggests babesiosis. Okay. So which of the following is vector for transmission of disease shown in following peripheral smear? Answer is ixoid tick. Ixoid tick transmits two disease. One is babesiosis and other is Lyme disease. Okay. In babesiosis, we already discussed, it will have symptoms similar to malaria and it will lead to hemolytic anemia. In Lyme disease, we have erythrum migrans. Erythrum migrans or bull's eye lesion. Bull's eye lesion. What is bull's eye lesion? I think I have a slide for that also. Yeah. So we will understand this bull's eye lesion in that diagram which I will show you. Okay. First, let's do two things. One is, let us have a clear understanding about all this vector, that how these vectors looks like, how we are going to identify this vector. And second, let's have a look at the peripheral blood smear of all these four diseases. That means 4 vector and 4 peripheral blood smear. If you know all these 8 things, then it might be that in the next time some question might come from these 8 things. Okay. So let's move one by one. This is the peripheral blood smear of babesiosis showing Maltese cross. This is a normal blood smear. You should know about this thing so that you can distinguish from normal peripheral blood smear. And this is monocyte, which is having bean-shaped or kidney-shaped nucleus. This is neutrophil, which is multinucleated. This is eosinophil having red granules, eosinophil, lymphocyte and basophil. Okay. Now, this is the diagram of ixoid tick. Okay. Ixoid tick looks like this when seen on your body, and when seen under microscope it looks like this. Okay. So as I told, ixoid tick transmit 2 diseases. One is Lyme disease, which is caused by Borrelia burgdorferi. Okay. This is transmitted again by ixoid tick, and the second is babesiosis. Babesiosis is again transmitted by tick. Okay. In this Lyme disease, what happen is erythema chronicum migrans, that is bull's eye lesion. The central part appear like bull's eye, and then there is this erythema, that means redness, which is chronicum migrans, which is chronic and which is migrating. So these are the 2 characteristic lesion of Lyme disease: bull's eye lesion with erythema chronicum migrans, and it is transmitted by tick. Okay. Now this is the life cycle. Again, man is a dead end of transmission, infected, and the tick may be present at deer or mostly at animals, dog skin. If you have a domestic dog, pet dog, you might have seen some ticks over his body. These ticks are responsible for transmission of Lyme disease and babesiosis. Okay. Okay. Now what is this? This is the diagram of a testis fly. Testis fly. It transmits African sleeping sickness. Okay. Very sorry. So this testis fly appear more like a house fly, but the only thing is he had a lower part which is more bulkier. Okay. And red, and then what will be the peripheral blood smear? How the peripheral blood smear of African sleeping sickness look like? African sleeping sickness, the causative protozoa is Trypanosoma brucei, and Trypanosoma brucei will comes itself. It is Trypanosoma brucei, and in the peripheral smear of African sleeping sickness transmitted by testis fly, you see this Trypanosoma brucei in the peripheral blood smear. Okay, simple. Now go to our third one, that is sandfly. Testis fly, I told you, it looks like a housefly and it transmits African sleeping sickness. Trypanosoma brucei. Then sandfly. How does sandfly look? Anopheles you must have seen, but let's look at how does sandfly looks like. This is the characteristic of sandfly. This is a sandfly. Okay. Leishmania is transmitted by sandfly. Leishmania is also commonly known as Kala Azar. Okay. So, what are the characteristics of a sandfly? Because the sandfly resembles a mosquito. So, you must know about the characteristic differences between a mosquito and a sandfly. First is the wing is feathery. First thing is feathery wing. Feathery wing is one characteristic which is not present in any mosquito. Second is the wing are mostly at around 90 degree to the body. Almost 90 degree. ठीक है? Wing at 90 degree to body. This is the second characteristic feature. The third is the legs are very large and the legs are also feathery. Legs, antenna, feathery wing and legs or antenna. Okay. This is characteristic of sandfly. As if sand is present all over its body. Sandfly. Okay. It transmits Kala Azar or Leishmania, don't know any. And this is the characteristic lesion of cutaneous leishmaniasis. Cutaneous lesion, cutaneous leishmaniasis. Okay. Now, how will the peripheral blood smear of cutaneous leishmaniasis will look? It will, on doing Gaiamsa staining, you will have LD bodies. What is this LD body? LD body is nothing but Leishmania donovani body. Leishmania donovani body. Okay. It is the amastigote form and it is present within the monocyte. Okay. So, on the peripheral blood smear, this is a peripheral blood smear of Leishmania. In the peripheral blood smear, this is the monocyte, and in the monocyte there are various LD bodies. What are LD bodies? They are amastigotes. Just remember it. Okay. Amastigote. Very sorry. I'm having chronic cough for last 2 days. Okay. And it is transmitted by sandfly and it is examined by Buffy coat film. Okay. Now, let's identify Anopheles, Culex. Let's identify the differences between Anopheles, Culex and Aedes. First is Anopheles sits at 90 degree. This is again one thing. Sits at 90 degree angle. Or in other words, we can say that it sits perpendicular to skin. Culex is having this humped configuration while biting. It sits parallel to the skin with a humped characteristic. Okay, humped appearance. And the thing with Aedes is known as tiger mosquito. That is characteristic of Aedes. Why he is known as tiger mosquito? Because he have black and white strips all over his body, all over his leg. Okay? So how can you identify black and white strips on body as well as on leg? This is characteristic of Aedes mosquito. Anopheles mosquito characteristic is it sits at 90 degree to the skin, and Culex, it sits parallel to the skin and it has an humped appearance. Okay, now look at the peripheral blood smear, okay, of all this these four type of Plasmodium. But the main thing is between Plasmodium falciparum and vivax, because these two are present in India. These two are rarely found in India. So in Plasmodium falciparum and vivax, there will be chromatin ring in both of them, but the ring of vivax is darker and it is light ring. Okay. The second thing, the gametocytes of Plasmodium falciparum will look like a banana, and that will be characteristic of Plasmodium falciparum. So this is Plasmodium falciparum because it have a banana shaped gametocyte. Banana shaped. If you see banana shaped gametocyte in the peripheral blood smear, it is because of Plasmodium falciparum. Clear? Okay. Now we also should look at the peripheral blood smear of both Plasmodium falciparum and vivax to distinguish between light ring and darker ring. Okay. Now this is the Plasmodium falciparum and these are the light rings. You can see light rings, light rings, light rings, light rings. These are all Plasmodium falciparum trophozoites. Trophozoites are vegetative forms. Okay. I will tell you about the life cycle of malaria as well. And what is this? This is the ring shaped trophozoite of Plasmodium vivax. Why? Because it is darker, and here you can see it's light ring. Okay. And these two dots, these are chromatin bodies. These are chromatin bodies. Okay. Now coming on to the life cycle of malaria, there is 5 salient point which I want to tell you, because it's come in various objective exam and you have to have a clear knowledge about it. First is that sporozoite form infects human. So the question comes is, which of the following form of Plasmodium infect human? Option will be gametocyte, sporozoite, trophozoite or vegetative form. The answer will be sporozoite form, infects human, or infects, other word, enters in human after mosquito bite. Okay. The second question that usually come is, gametocyte form it infects mosquito, or in fact also mean it enters in mosquito after biting human. Okay, infects or enters in mosquito, because it's not that only mosquito transmits malaria to human being. Even human transmit malaria to mosquito. Okay, if you are a person having malaria infection and if an innocent mosquito who is not having malaria bites you, he will also have malaria parasite. Okay. So, but then again when he bites some other human being, then he transmits the malaria from one person to another. So this is the second question. Now the third question is, ring form or trophozoite is present in RBC of man, and it is vegetative form. Vegetative means not multiplying, vegetative form, not doing reproduction. Okay. And the fourth question is, Plasmodium vivax Vivax causes relapse relapse of malaria because it has an exoerythrocytic cycle. Erythrocytic cycle in liver. Okay, so you have to remember these 4 points, but you need not to mug it up, just understand it with this life cycle diagram. Here, my first point was that sporozoite is the form which enters in human being. So a mosquito bites you and it gives sporozoite inside your body. Then these sporozoites go into RBC and they multiply and then they form the ring form. This is the ring form, which is also known as trophozoite form. Okay, this ring form is present in RBC, erythrocytic cycle. This was my third point. Then if from your RBC, which is going to be circulated everywhere in your body, the mosquito bites and it takes the gametocyte. So mosquito takes gametocyte. This was my second question. Then these gametocytes go inside mosquito body, and here it get transformed into microgamete and microgamete. This microgamete and microgamete fertilize, form ookinete and enters in the abdominal wall of mosquito. From there they are transmitted to the salivary gland, and then they get transformed into sporozoite, and from the salivary gland of mosquito these sporozoite form enters into human body. What was my fourth question? My fourth question was that who among the following produces relapse? So does not produces relapse. So Plasmodium falciparum is the only strain which does not produces relapse. All the 3 form, Plasmodium vivax, ovale and malaria, they produce relapse. How they produce relapse? They enter into liver cell and they lead to exoerythrocytic cycle. And what happen is that suppose Plasmodium vivax enters into liver cell, it remains dormant for some time, then after 1 month, 2 months or some duration, it again comes to RBC, again come in your blood, and it again lead to malaria fever. So this again and again fever of malaria is known as relapse of malaria, and it is because of exoerythrocytic form of malaria which is present in liver and which is characteristics of Plasmodium vivax, malaria and ovale, but which is not present in Plasmodium falciparum. Okay, clear? 4 point clear. Sporozoite form infects human, gametocyte form infects mosquito, ring form or trophozoite is present in RBC of man and it is vegetative form, and Plasmodium vivax causes relapse of malaria because it has an exoerythrocytic cycle in liver. Okay. Now, the last question which may come is regarding the eggs and larvae of Anopheles. Okay. Again, you need to remember 2 points. One is Anopheles floats. Why it floats? Because egg half floats, and because larva have no siphon. The other thing which you have to know is culex have both raft and siphon. Okay, and so let's go to this diagram. You see the question which usually come is which of the following have floats? Answer is Anopheles. Anopheles eggs are laid singly. This is the second point. But culex leg are laid in raft. This is the point which you have to remember. Only culex laid its egg in form of raft. Okay, and there are no floats in eggs of Aedes and culex, but floats is present in Anopheles. Then larva of Anopheles, it floats around the surface, parallel to the surface. But larva of Aedes and Culex, they are present at around 45 degree to the surface, or they are seen hanging. They are downward in the surface. They are not present at the surface. Why is it the case? The reason is that the larva of a mosquito have rudimentary breathing tube or no siphon. What is siphon? Siphon is a long stick-like breathing tube. So these larvae can float because they have a tube which goes outside and takes the oxygen. But it cannot float because it doesn't have that tube. So the larva of Aedes and Culex can go down in water and can hang down from the surface because they have siphon tube. Okay, they have air tube or siphon tube. Okay, so only larva which is found floating at the surface is Anopheles. Only larva which has float is Anopheles. That's why I write Anopheles floats, because it has egg, have floats, and larva have no siphon. So present at surface of water. The larva is present at surface of water, it floats. But Culex have raft and siphon. Raft means egg laid in group. Egg are laid in group, that is raft. And siphon is the respiratory tube. Which help in going down in water, Okay, clear? So that's why Culex remain down. So what you have to remember, Anopheles floats, one thing, and then Culex have raft and siphon. Is another thing. Okay, there is no peculiar thing about Aedes. Aedes have a single egg, no float, and it have siphon. Okay, clear? Now let's move to another question. These are some of the concept based questions for which you need to develop some concepts as well, along with mugging the facts. The question is, a disease occurred and within its incubation period, other patients are infected. This is known as. What is incubation period? Incubation period means interval between entry of pathogen and appearance of first symptom. Correct. Appearance of first symptom. What is the difference between symptom and sign? Symptom is what patient tells us, that I am having pain, I am having itching, these are symptoms. What is sign? Sign is what doctors see in the patient. For example, a patient comes to you with complaint of headache, with a complaint of palpitation and headache, and then you measured the blood pressure and find that the blood pressure is raised. So the complaint of the patient is the symptom, and sign, you palpated the pulse and find that the pulse is hypovolemic, then this is the sign. Okay. Patient comes to you with complaint of yellowish discoloration of sclera in jaundice, and you find out that the patient is, along with this yellowish discoloration of urine and sclera, there is discoloration of nail as well, and the patient is also having loss of hair, also having other symptoms of liver failure like swelling in the foot or dependent part of the body. So these are the signs which you find out, and symptoms are things which patient tell. So incubation period is the difference interval between entry of pathogen and appearance of first symptom. Okay. Then the question asks that a disease occurred and within its incubation period other patients are infected. If only one bout of patient are infected, bout means only one group of patients are affected, it is primary attack rate. But since within its incubation period other patients are infected, it is known as secondary attack rate. Okay, let's understand the definition one by one. Let's first understand definition of serial interval and generation time. Let me, here you can see this line, this point, it says infection, entry of infection. Okay, entry of infection. So what will be the incubation period? Entry of infection to appearance of first symptom. This is incubation period. What is latent period? Entry of pathogen to the duration up to which disease cannot be detected. That means no serological evidence, no evidence of antibodies or anything, evidence, and no symptom. This is latent period. Okay, and incubation period is the difference between entry of pathogen to appearance of first sign and symptom. For example, I am having chronic cough, so this is a symptom, and the incubation period is like for 3 days back I went to airport to receive one of my friend, and while going there I might have caught cold and flu. So this 3 day is the incubation period. Like if I developed cough today, then this will be the incubation period. But what will be the generation time? Generation time is the difference between entry of infection to maximum infectivity. Maximum infectivity. Okay, I developed chronic cough in 3 days incubation period, but if I do not take any medicine, then after 2 days I will be having a cough which will be productive and which may spread to all of my friend who comes in contact to me. So then that will be the generation time of 5 days will be the generation time, the duration between entry of pathogen and appearance of maximum infectivity. Okay, now what is serial interval? Suppose here you get infected, one patient get infected, and again one more bout of patient get infected. Okay, so this will be the serial interval. The duration between maximum infectivity of two disease is serial interval. This is serial interval. The duration within which the disease is transmitted. The median incubation period between two bouts of infection is serial interval. Okay, the duration between which one group of patient, average of one group of patient getting infected infects other group of patient, that duration is known as serial interval. Okay, and this time, generation time, is the duration between entry of pathogen to appearance of maximum infectivity. Okay, now look at other two concepts, that are primary attack rate and secondary attack rate. Okay, for that let's solve one common question, that in a family, suppose there are 6 children, okay, out of which one is totally immunized, completely immunized. Completely immunized means taken all the vaccination of first year. That is the definition. Okay, immunized. And 2 child develop measles. Okay, then within 4 days within 4 days one more child develop measles. Okay, then the question is, what is primary attack rate and what is secondary attack rate. Okay. So how will you calculate primary attack rate? Primary attack rate is number of children infected by number of susceptible children. Okay. So in this case, what is the number of children infected? In the first number of children infected in first exposure. In first exposure is the primary attack rate. So what are the number of children that are infected in first exposure? That are 2. Divided by number of susceptible children. What are the number of susceptible children? There are total 6 children, out of which 1 was immunized. Okay. So the total will be 2 by 5. And if it is multiplied by 100, then we can get it, the attack rate in percentage. So 2 by 5 is the primary attack rate. If it multiplied with 100, then the primary attack rate will be 40%. Okay. Okay. So primary attack rate is number of children infected in first exposure divided by number of susceptible children. Susceptible children means those who can develop the disease. Since 1 is immunized, okay, out of which 1 is totally immunized. So this 1 is here, 1, this 1. We minus 1 from the list of susceptible children. So the primary attack rate will be 40%. Now the question remain is secondary attack rate. What will be the secondary attack rate? The definition of secondary attack rate is number of exposed person developing the disease within incubation period or number of cases among contact of primary cases during the incubation period divided by total number of contacts into 100. Let me simplify it. In this case, secondary attack rate means number of person or children infected in second round, simply second round of infection. Okay. When it is divided by number of susceptible children, again into 100, it will be secondary attack rate. So in our question, within 4 days, 1 more child develop measles. So this 1 more child get affected in the second round of infection. Second round of infection will have 1 child, only 1 child, second round. Now number of susceptible children, total children are 6, 1 is immunized. Plus now we will also subtract those children who developed infection during the first round. What are those children? 2 child. 2 child developed infection in the first round. So we also subtract 2 from here and then we multiply it with 100. The answer will be 1 by 6 minus 1 will be 5. 5 minus 2 will be 3. 1 by 3 into 100. So the secondary attack rate will be 33% and the primary attack rate will be 40%. Okay. You need to solve more questions based on primary and secondary attack rate to bring this concept of primary and secondary attack rate in your permanent memory. Okay. But it's very simple. Okay. Primary attack rate is number of children infected in first round of infection or first exposure round divided by number of susceptible children into 100, and secondary attack rate is number of children infected in second round of infection divided by number of susceptible children into 100. In the secondary attack rate, from the denominator you also subtract those children which are infected in first round. Okay, that's the only difference between primary and secondary attack rate. Okay. Now let's move to another question. A contraceptive was used for 24 months by 100 women, out of which 10 become pregnant. then what is the Pearl index for this contraceptive? What do you mean by Pearl index? Pearl index is a measure for failure rate of any contraception. Failure rate of contraception. It measures failure rate of contraception. And the formula to measure Pearl index is very simple. It is total accidental pregnancy divided by total month of intake, and it is also multiplied by total women who are taking it, total number of women taking it, and then it is multiplied by 1200. Okay, so in this case, what was the total accidental pregnancy? 10 become pregnant, है ना? 10 become pregnant. So this is 10 divided by total month of intake. Month of intake was 24 month. So you write here as 24. And total women, number of women taking it. Number of women will be 100 women. So you multiply it with 100. And then the total is multiplied by 1200. So what will be the answer? Pearl index in this case. Pearl index, total accidental pregnancy divided by total month of exposure divided by total women taking it into 1200. This is Pearl index. So 24, 12, they get cancelled by 2, 2, 10, 5, 20 with 20. So the Pearl index will be 5. Answer to this question will be 5. Very simple. Okay. The only thing you need to remember is this formula. Total accidental pregnancy divided by total month of intake multiplied by total number of women taking the contraceptive into 1200. Okay. Simple. Along with Pearl index, life table analysis is also used to measure failure rate of contraception. But the better measure is Pearl index. Pearl index is better measure. Index is better measure. Why better measure? Because in life table analysis, you take the data based on total number of female who are left even after 1 year or after 2 years of time. But since many women will leave taking the tablet in between of 1 year, 2 years, so life table analysis is not feasible, and Pearl index is more simpler to use. Okay. Now, incidence of disease is 4 per 1000 in a population of 5000, and it occurs for mean interval of 24 months. What is the prevalence of disease? Okay. There is this thing, prevalence. What is prevalence? What is incidence? Let's understand it with a simple example. That if in a class, suppose at any time there are 3 students out of 50 who have chronic cough, then this 3 is the prevalence. This is the prevalence. Suppose a researcher or what I did is I followed all the students for 4 days, and I found out that 2 more out of those 53 were having the TB, 3 were having the chronic cough, and 2 more developed chronic cough in that duration of 3 weeks. So that 2 number of cases which came during the period of observation is the incidence, because incidence is only new cases, and prevalence is existing cases, present cases, already present cases, existing cases. Okay, this is the difference between incidence and prevalence. Prevalence cannot be known at that time. Prevalence can be known at that time, but incidence cannot be known at that time. For to know the incidence, you have to follow the patients, you have to follow the group. Okay, so in this question, incidence is 4 per 1000 in a population of 5000. So what will be the total incidence? Total incidence will be, पहले क्या है, 4 in 1000 है, तो 5000 में कितना हो जाएगा? 4 in 1000, ठीक है, 4 in 1000, so 5000 में कितना हो जाएगा? 4 into 5, that is 20 in 5000 हो जाएगा. How? Because 1000 में 4 है, तो in 5000 4 into 5 हो जाएगा. That means 20 in 5000 is the total incidence will be equal to 20. ठीक है, जैसे we calculate it like that ना, कि 4 in 1000, so 1 in 1000 by 4. Okay, and then in 5000 we have 1000 by 4 into 5. देखो, to calculate total incidence, we multiply incidence in 1000 into incidence in one population into total population. Incidence in one individual into total population. Now what is the incidence in one individual? There were 4 cases in 1000. So for 1000 individual, there will be 4 cases, or for one individual, there will be 4 by 1000 cases. One individual, 4 by 1000. So incidence in one individual is 4 by 1000. When it is multiplied by total population is 5000. We get the answer. 1000 will be cancelled and 4 into 5 will be 20. So total incidence will be 20. Now we all know this simple formula that in prevalence is equal to incidence into duration. Incidence into duration. In this case, the incidence of the of disease in the whole population was 20, and duration was 24 month. You can see 24 month. So 24 month will come out to be 2 year. 24 month will be equal to 2 year, and hence 20 into 2 will be 40. So the answer will be 40. Simple. So we do not take duration in month. Duration is taken in year. So the definition of prevalence is incidence into duration in year. Incidence in population by duration in year. So it will. Let us understand this concept of incidence with help of this animation diagram. Incidence is this cases, new cases entering in a community, new cases occurring in a community, occurring or entering in a community. ठीक है. And prevalence will be this much of the thing that remain in the community all the time is the prevalence. Out of all these cases, some will be cured, some will die. Okay, and if you do intervention like immunization, immunization prevent death, and by preventing death, it will increase the duration. Because if the people will die, they will be drained out, and hence the prevalence will decrease. But if the patient are prevented by immunization or by some other process, then the duration of illness will increase, and hence the prevalence will increase. Okay, so prevalence depend on two things, incidence and duration. If a disease is very lethal, the duration will be very less, and hence prevalence is very less. Okay, for example, Ebola virus. Recently, Ebola outbreak happened in Africa. The prevalence was very less because there were many incidence cases, but all the cases used to die within 1 week. So duration was very less in a year. It was very less. So the prevalence was less. But if you take example of tuberculosis, which remain for like 6 months at least if properly treated, or 1 year, then even if the incidence is not very big, the duration is very big. Hence the prevalence of TB or prevalence of diabetes, hypertension, they are very large, because in all these cases duration is very big. Okay, clear? Prevalence is incidence into mean duration. If there is 10 cases every 1000 population, in 5 years the prevalence will be 10 into 50, 50 per 1000 population. Okay, clear? Prevalence rate can also be understood with this example, that there are 10 new cases of Klebsiella in January, and total of 17 cases of Klebsiella occurred in that month, but new cases, they will be the incidence, है ना? And this 17 will be the prevalence. So incidence rate for month of January is 10 out of total resident 250 is 4%, and prevalence rate for month of January will be, prevalence is 17, so it is 17 by 250 into 100. Simple. Okay, let's move to another question. Which of the following is unit of study in ecological study? Okay, the answer is population, because in all of our study the unit of study is individual, except for ecological study, in which the unit of study is population. Let's understand it in a bit more detail. See, studies are broadly classified into two types. One is non-experimental or observational study, in which we or scientists do not interfere. Do not interfere. This is non-experimental, and non-experimental is also known as observational study. Okay. Then second type is experimental or interventional study. In the experimental study, there can be randomized trial, okay, and there can be non-randomized quasi-experimental field trial or community trial. What are field or community trial? Suppose there are two Harijan Mohalla in two nearby villages, and in one village we did an intervention and we formed their self-help group. That is, group of all the people meet together once a month and assemble some of their money, and with the help of that money saving activity, we help them to start some of their own business. So after 1 year or 2 years of time, that Harijan Mohalla having self-help group will improve. Then we will compare this Harijan Mohalla with the one in which we have not done any intervention. Only government program that is already present in the community is implemented in that community. So this type of experiment is quasi-experimental field trial or community trial. Okay. Then what is RCT? In RCT, we give a drug to one group of patient and a placebo to other group of patient, and we observe the change. This is example of RCT. Okay. Now coming on to other type of a study. What are the other type of a study? Studies can be population based or individual based. If it is population based, it can be descriptive, in which it describe about the situation. For example, if immunization is present in 60%, it will be health survey. That will only describe whether the immunization rate is 60% or 70%, only describe it. But it will be an analytical study if it will be an ecological study, in which we also try to find out in which zone the rate of immunization is less. For example, in slum area, the rate of immunization will be less than the normal area. And that analysis, why this rate of immunization is less in one population than another, is done in ecological study. But the cause is not found out. For that, we need to perform individual based study, because the cause vary from each individual to other individual. And in that, if it is only descriptive, then it is case report or case series. Case report is one for one patient, and case series for group of patient. Case report is based on disease that is present in one patient, and case series is for group of patient, that is group of patient. On group of patient, if we find out any peculiar characteristic, then we prepare case series. But if we found any peculiar tumor or disease in one patient, then it will be case report. Okay? What does analytical mean? Analytic means when we are trying to analyze the cause, when we are trying to find out why this disease happened or why this characteristic is present in this individual, then that will be analytical study. And analytical study is of three types: cross-sectional study, which is known as prevalence study. It is also known as one-time study. One-time study. Photographic study. Because in cross-sectional study, we, for example, in a photograph, we can only know about those students who are present at that time while the photograph is taken. So similarly, in cross-sectional study, we can know only about those diseases which is present at that time, and that is prevalence. I told you, I gave you an example in which I asked you that in this class, if 3 of the student is having chronic cough, then all these cases will be known as prevalence. Their prevalence of chronic cough will be 3. And if I followed your whole class for 3 weeks and I found that 2 new cases developed, then it will be incidence. Okay? So in cross-sectional study, we can only know about prevalence, because we are not following the group. Okay? And hence it is known as one-time study or photographic study. Okay? Case control study. Okay? In case control study, what we do is, you have to know case control and cohort in a bit more detail. In a case control study, the disease had already happened. Disease have already happened. Okay? Okay? Suppose we take 2 group of driver. One group having accident, had accident, and one group no accident. Okay? Suppose the group that had accident was 5 and the group that had no accident was 500. Okay? So in both of this group, we will ask whether you drink before driving or not. Okay? And the same question will be asked from it, that is whether you are a chronic drinker or not. Chronic drinker, whether you are a chronic drinker. The same question is asked from both the group. Okay? And suppose out of this 5, 4 said that yes, we are chronic drinker, and we drink on that day on which accident happened. And out of this 500, suppose 10 said, yes, I am a chronic drinker, but I did not have accident. Okay, so this type of study will be a type of case control study. Why? Because disease have already happened, accident has already happened, and we go back in time. We go back in time and ask about exposure. That is, ask about how the disease happened, exposure or risk factors, risk factor for that disease. Okay, so this will be a type of case control study, because in this study disease have already happened and we go back in time and ask about exposure or risk factor to that disease. Hence this disease is also known as retrospective disease. Why retrospective? Because we are going back in time, retrospective disease. Okay, okay. Suppose now in a cohort study, you know that drinking alcohol might cause accident, so you make two group. Here again this was two group, had accident was cases and this was control, no accident was control. In this case you take cases as driver who are chronic alcoholic, chronic drinker, and control who are driver who are non-drinker. Then both of these driver are followed for 1 year, followed for 1 year, followed or observed, the same thing, observed for 1 year for any accident. Okay, and you took both cases and control as equal, so 1000 cases and 1000 control. Okay, in these cases who are chronic drinker, suppose 20 underwent accident, and in these cases who are control, only 4 accident happened, 4 accident, 20 accident. Okay, so in this what you do, we observe for 1 year, we observed for 1 year, we followed for 1 year. So this is a study in which we move forward in time, we move forward in time and observe number of diseased in cases and control, in exposed group and non-exposed group. Okay, see, this is the non-exposed group because they are not drinking, and this is the exposed group because they are drinking. So cases is also known as exposed group, and control is also known as non-exposed group, non-exposed group. Okay, so in a cohort study we move forward in time, we do follow up of patient, we move from exposure to disease. Okay, so this cohort study is also known as prospective study. Why prospective? Because we move forward in time, prospective study. Okay, okay, clear? So this is cohort study. Okay, so the question which was there was, which of in unit of study, which of the following is the unit of study in ecological study? The answer was population, and participant is the unit of study in case control, in cross-sectional and in cohort. I already explained it with example that in all these example we are observing each driver. So driver is a participant. So both case control and cohort study is based on participant. Similarly, in cross-sectional study, we asked how many of you have chronic cough at this time. In this, I inquire about each of the student. So again, this is a participant-based study. Okay. But in ecological study, suppose I want to know about immunization rate of measles in a population. Then this is an ecological type of ecological study, and ecological study is based on population, not on individual. Okay, clear? Very good. Now let's move to our another question. Okay. The question is incidence of disease in exposed divided by incidence of disease in non-exposed is defined as. Okay. The first thing which I told you is that incidence, to calculate incidence or to know incidence, what we have to do? We will have to follow the patient. We will have to follow the subject. Follow the subject. Without following, we cannot know about incidence. Okay. For example, if I asked how many of you have chronic cough at this time, that will be prevalence. But if I followed your group, your class for 3 weeks, and I found that 2 new cases developed during that 3 weeks, then that will be incidence. So to know the incidence, I have to follow the group. To know the prevalence, I can know it with a cross-sectional study anytime. Okay? So incidence of disease can only be known if we follow the subject. And what is the study in which we follow the subject? We follow the subject only in cohort study and RCT. Follow the subject in only 2 types of study, cohort study and RCT. In only 2 cases we follow them. Okay. In all other cases, like in cohort, we move forward and followed them, observed, followed for 1 year. But in case control, we asked question from past. We asked question from past. That is whether you were chronic drinking or not. So in case control study and cross-sectional study, we do not follow. Therefore, incidence can only be known in 2 studies, cohort study and RCT. And incidence cannot be known in case control study. Incidence cannot be known. This is one thing which you have to remember, because many a time objective comes directly that incidence can be calculated in which of the type of study. The answer will be cohort. Incidence cannot be known in which studies? Cannot be known in case control study or in cross-sectional study. So to know the incidence, we have to do either cohort study or RCT. Now, incidence of disease in exposed divided by incidence of disease in non-exposed is defined as relative risk. This is the formula of relative risk. But now let's understand the difference between all of these 4 terms: odd ratio, relative risk, attributable risk, and population attributable risk one by one. Okay. Now first is relative risk. What is relative risk? Incidence of disease in exposed by incidence of disease in non-exposed into 100. This is the relative risk. Suppose in our example, we had taken, let's draw this square. This square, you see a lot of time while calculating sensitivity, specificity and all, and you write A, B, C, D in the 4 table. But before writing A, B, C, D, you have to be sure about one thing, very sure about one thing. What? That disease has to be present on the uppermost side, and test or exposure or risk factor is to be written at left hand side. If you change this pattern, if you write disease on left hand side, then this whole A, B, C, D will change, and all of your formula will also change. So in your exam, if there is already a table is given in the question, then you have to turn the table into this format first before applying any formula. If you simply applied the formula and did not turn the table, then you will do a wrong calculation. Okay, so be sure that disease in upper side and test is in the left hand side. Okay, this column test, for example, in this example you have done a cohort study on drinking driving. Okay, so disease is accident and no disease is no accident. Test is drinking present, drinker, and they are non-drinker. This group was non-drinker. Okay, drinker and non-drinker. Suppose in our example, what we have done is total number of drinker and non-drinker were both 1000. Total number of accident that happened, 20 accident in drinker group and 4 accident in non-drinker group. So accident in drinker group was 20, accident in non-drinker group was 4. What remain? If you subtract 20 from 1000, it will be 980, and this will be 996. Okay, so what will be the relative risk? Relative risk here is odds of having the disease in exposed, incidence of disease in exposed. So what is the total number of exposed? What is exposure here? Exposure is the drinking. So this 1000 is total exposed population. Okay, and this 1000 is total unexposed population. Okay, so relative risk is incidence of disease in exposed. Exposed was 1000 and incidence of disease in exposed was 20. Only 20 accident happened in exposed, so incidence of disease was 20. And in the denominator, incidence of disease in non-exposed. Non-exposed was total again 1000, but out of 1000 how many developed accident among non-drinker? Only 4. So this will be relative risk. It will be 20 by 4 or 5 aa jayega. Relative risk is 5. Now what will be the formula of relative risk? Here you are writing 20, that is A, and what is the 1000 indicate? It indicate A plus B, A by A plus B, simply. And what will be the denominator? Incidence of disease in non-exposed. This is non-exposed or non-drinker. Incidence is 4, and you can also say it's C. 4 is C. It will be divided by total non-exposed. Total non-exposed is C plus D. So the formula for relative risk is A by A plus B divided by C by C plus D. Okay. Sorry. C by C plus D. Okay. This will be the formula for a relative risk. Okay. Now coming on to understand odd ratio. What is odd ratio? Odd ratio is Again, odds of having the disease in exposed divided by odds of having the disease, odds of having the exposure in disease, odds of having the exposure, क्योंकि here you are measuring exposure. You know, in odd ratio is calculated in only in case control study. In all the case control study, you already know which of the following have already developed the disease, and you try to find out whether exposure was present or not present. For example, in this case control study, accident had already happened, so this was the disease. Disease was already present, disease absent, and you try to find out whether exposure was present or not. Exposure was present or not. Disease you already know. You want to know whether they were drinking while having accident or not. So you know about disease, but you do not know about whether the exposure was present or not. So in odds ratio, odds of having the exposure in total diseased by odds of not having the exposure, odds of having the exposure in non-diseased, okay. And the formula for this will be similar to relative risk, A by A plus B divided by C by C plus D. Simple. But what happened in odd ratio is, if you see in this example, A and C are negligible to B and D, because B and D is very big, okay, and A and C are very small. Like C is only 4, D is 996. So in odd ratio, since odd ratio is only in case control study, and in case control study we study about rare disease, so A can be neglected from A plus B, and C can be neglected from C plus D. Why it can be neglected? Because C is only 4, D is 996, so the total will almost be equal to 996, so C is negligible. Again, A is only 20, whereas B is 980, so 20 can be neglected in terms of 980. So if we remove this A and C from the denominator, what will we get? We will get A by B divided by C by D, and this will come out to be AD by BC, because this will go upward, ये ऊपर चला जाएगा. So let us understand the concept of attributable risk and non-attributable risk. Okay, population attributable risk. So we understand what does relative risk and odd ratio means. Okay, now what is attributable risk? Okay, attributable risk is risk in exposed. Okay, let's understand what does attributable risk mean. Okay, attributable risk is risk is equal to disease in exposed minus disease in non-exposed. Okay, divided by disease in exposed. Into 100. This is attributable risk. Okay, Just now we understand with example of drink and driving that disease in exposed means total number of drink and driver who developed accident. Accident was the disease and exposure was drinking alcohol. So that was 20 here. See, 20 developed accident and 20 out of 1000, 20 were drinker. So disease in exposed is 20 by 1000 minus disease in non-exposed, only 4 got accident out of 1000 who were non-drinker, divided by 20 by 1000 into 100. This will be attributable risk of driving. Okay, attributable risk of drinking on driving. So here you will get 20 minus 4 by 20 into 100, that is 16 by 20 into 100. Okay, so the attributable risk is 20 will 5, so it will be 80%. Attributable risk is 80%. That means if you are drinking and driving, then the chance of accident increases by 80%. Okay, this is attributable risk. Simple. Now let's move to population attributable risk. Population attributable risk formula is similar to attributable risk. Okay, in population attributable risk we will write disease in population, okay, minus disease in non-exposed divided by disease in total population. And this will be multiplied by 100. Now since here we do not know what is the population, so we cannot calculate population attributable risk. Okay, but suppose if we have that information, then only we could have calculated population attributable risk. Okay, so let us go back to the question. The question was incidence of disease in exposed divided by incidence of disease in non-exposed is defined as, answer is relative risk. Okay, attributable risk is disease in exposed minus disease in non-exposed divided by disease in exposed. Simple. And in population attributable risk we have disease in population minus disease in non-exposed divided by disease in population. So the formula for both attributable risk and population attributable risk is same, as disease in non-exposed is common in both of them. Only what we have done is we have changed disease in exposed with disease in population. Disease in exposed with disease in population. Okay. So if you remember population of formula for attributable risk, and you replace disease in exposed to disease in population, the formula for population attributable risk comes out. Okay, simple. Okay, so for the formula for relative risk is A by A plus B divided by C plus C plus C by C plus D. The formula for odd ratio is AD by BC. Formula for attributable risk is this, and formula for population attributable risk is this. You have to remember all this formula and kindly do apply this formula on some of the question which you get in PSM exam. Then only you will be sure that you can solve such type of question. Okay. Now this is an example. Again, it based on the same thing, that if you are drinking and then you developed accident, then 70% out of 7,000 who were drinking had accident. So incidence rate among drinker is 70 by 7,000, that is 10 per 1000. Now incidence in non-exposed is 3 in 3000, 3 by 3000, so it will be 1 in 1000. Okay. Relative risk means incidence in exposed by incidence in non-exposed, 10 by 1, that is 10. And attributable risk is disease in exposed minus disease in non-exposed by disease in exposed, exposed into 100, so that will be 90%. Clear? Okay. Okay, let's move to another question. For India to achieve NRR of 1, what should be the minimum couple protection rate? NRR stands for net reproduction rate. Okay. What is net reproduction rate? Before knowing net reproduction rate, we should have a concept about general fertility rate, total fertility rate, gross reproduction rate, and then net reproduction rate. What is for general fertility rate? General fertility rate. Fertility rate. General fertility rate is number of newborn born to total female population. Number of newborn in that area divided by total female population of that area into 1000. This is general fertility rate. Now, if you assume, or if you take it in age group of 5, that means if you are calculating number of newborn in female, suppose of age group 20 to 25, okay, and you are dividing it with total female of the age group 20 to 25, then it become age specific fertility rate. So what is age specific fertility rate? Number of newborn in a definite age group divided by total female population in that age group. In that age group, and this is multiplied by 1000 in that age group, and this is multiplied by 1000. So number of newborn if in 5-year age group. To calculate total age specific rate, we sum up all the population in age group of 5. Okay. To simplify it, what we mean by age specific fertility rate is that what are the fertility in female who belong to age group 20 to 25. Of course, those female who are in the age group 20 to 25 will have more fertility rate than those female who are in the age group 40 to 45. Okay. So that age specific fertility rate helps us to find out the fertility rate in a specific age group. So we sum up all the 5-year age group and we get age specific fertility rate. Okay. Now, after age specific fertility rate, the next is total fertility rate. Total fertility rate. What is total fertility rate? It is sum of all age specific fertility rate by 1000. That means from age group 15 to 19 and from 45 to 49. This is the upper and lower and upper limit of age group. Okay. Total fertility rate means, it means total newborn given birth by a couple is total fertility rate. Okay. Now what is gross reproduction rate? I'm telling you about all this term because various objective questions have came from these specific terms. So if you have concept of all of these terms, you can solve a lot of multiple questions. Okay. Coming on to gross reproduction rate. Okay. Gross reproduction rate is total female child born to a couple assuming no mortality. Assuming no mortality. mortality. Okay, it is total female child born to a couple assuming no mortality. That means total newborn is taken in total fertility rate and only female is taken in gross reproduction rate. As in a population there is 50 chance of male and female child, that means half of the child will be male and half will be female. So gross reproduction rate is half of total fertility rate. Do you understand it? Why gross reproduction rate is half of total fertility rate? Because gross reproduction rate include only female child and total fertility rate include both male and female. So out of this male and female, half will be female. So half of total fertility rate will be equal to gross reproduction rate. Okay. I will explain it to you further with one example in next page. Okay. Okay. Let us add one more slide to it so that I can explain to you about net reproduction rate as well before explaining it in combination to each other. Okay. Let me, so net reproduction rate, what is net reproduction rate? Net reproduction rate is total number of female child born to a couple, net reproduction rate. It is total number of female child born to a couple, female child born to a couple assuming or taking into account assuming normal mortality rate. So what was the difference between total fertility rate and gross reproduction rate? The difference was in total fertility rate we used to take all newborn, but in gross reproduction rate we take only female child. Okay, and in net reproduction rate we take only female child, but we also take the mortality rate, the normal mortality rate. To explain it further, let us take one example. In a family or a couple gave birth to 2 male and 2 female child, ठीक है, out of which one girl died at 6 months of age. And the question is to calculate total fertility rate, gross reproduction rate and net reproduction rate. ठीक है, you have to calculate all these three. The question is having 2 male and 2 female child. So total fertility rate is equal to total number of child born to a couple. It will be 2 plus 2 and hence it will be equal to 4. Gross reproduction rate is equal to total female child born to a couple. It will be only 2 plus 0 because only 2 girl child. So gross reproduction rate will be 2, that will be half of TFR if the boys and girls ratio is equal. And then net reproduction rate. Net reproduction rate will be equal to 2 minus 1 equal to 1. Why minus 1? Because one girl died at 6 months of age. This one girl who died at 6 months of age is taken in net reproduction rate but not in gross reproduction rate. Net reproduction rate is total number of female child born to a couple assuming normal mortality rate Yani if as taking into account all the death that happened. Okay. So net reproduction rate, to calculate net reproduction rate, we will subtract the number of girl child who died out of total born girl child. But to calculate gross reproduction rate, we will simply write all the girl child that are born to the couple. We will not subtract anything. Okay. Clear? Go back and revise the formula from your book as well. But this is the concept behind total fertility rate, gross reproduction rate, and net reproduction rate. Okay. Now moving on to next question. According to World Health Organization non-communicable disease guideline, communicable disease guideline, prevalence of hypertension to be reduced by 2025 is, answer is 25%. This is a question which you have to mug up. We have to reduce prevalence of hypertension to 25% by 2025. What is this? This is global NCD target to reduce high blood pressure. And there was total of 9 global NCD target, which was taken for global NCD action plan. And in that, global target was 25% relative reduction in prevalence of raised blood pressure by 2025. So the answer is 25%. Now moving on to next question. Decontamination activity of bleaching powder is because of which of the following ion? This is hypochlorous ion, also known as HOCl minus ion. This is hypochlorite ion, HOCl2 minus ion. Okay. This is chloride ion, Cl2 minus ion. And this is phosphorus ion, that is phosphorus ion, 2 minus or 3 minus. Okay. So this is hypochlorous ion, and this hypochlorous ion is responsible for decontamination activity of bleaching powder. So in your question, they might also give you this ionic formula as the option. Again, the answer will be hypochlorous ion. What is the formula for bleaching powder? Bleaching powder is CaOCl2. OCl2. Okay. This is bleaching powder. What is bleaching powder? What does bleaching powder does? It decontaminate. It kills all the bacteria present in the water with help of its, mainly because of its hypochlorous ion. This is the main decontaminant ion. So there are two more questions related to chloride ion. First is chloride ion concentration for normal water is 0.5 to 0.8 ppm for drinkable water. Second is second point is कि if you want your water to be free from bacteria, you need at least the residual chlorine amount required in drinkable water. Water is 0.5 after 1 hour of contact. What does this line mean? It means, suppose there is a cholera spread in a region and you want to decontaminate the well. So you put bleaching powder in the well, okay, to find and that bleaching powder will leave some chlorine ion in the water. So if that chlorine ion concentration is 0.5 milliequivalent after 1 hour of contact, it means the decontamination work which you have done was good. It means that the water in which you have put bleaching powder is now decontaminated. The water is said to be decontaminated only if the chlorine ion concentration after 1 hour of giving bleaching powder is only 0.5 milliequivalent per liter. Okay. Now there are two tests. One is orthotoluidine test. And other is orthotoluidine arsenite test. It detects both free and combined chlorine, because if chlorine is present in free form, only then it will lead to decontamination of water. So orthotolidine test detect both free and combined chlorine present in water. But what is orthotolidine arsenide test? Orthotolidine arsenide test, it detects free and combined chlorine separately. Chlorine separately. So it is better because the decontamination activity of water is because of free chlorine. So if you want to know whether the water is having proper or adequate amount of chlorine for decontamination action, then you need to know about free chlorine present in the water. And that free chlorine can individually be told to you by orthotolidine arsenide test. But if the test is only orthotolidine test, you can detect the amount of chlorine, but you will not be able to find out whether that chlorine is free chlorine or combined chlorine. Okay, so these are the 4 main objective questions which arises from this topic, and you have to remember this 4 point as well along with this hypochlorous ion. Okay, now, and apparatus which is used to measure chlorine demand is Horrocks apparatus. Horrocks apparatus. What is Horrocks apparatus? It consists of 6 test tubes in which you put water and estimate the chlorine amount. The Horrocks apparatus is used to estimate chlorine amount required for decontamination. That means if you want to know how much of bleaching powder you want to put in the water so that water have 0.5 ml of chlorine after 1 hour of contact, then you use Horrocks apparatus. Horrocks apparatus consists of 5 tubes in which you put water and calculate that how much amount of bleaching powder is required to be put in the well so that water will have 0.5 milliequivalent of chlorine after 1 hour of contact. Why 0.5 milliequivalent of chlorine? Because that much is required for water, because that 0.5 ml is required for decontamination activity of chloride. Okay, so let me revise this whole concept. There is a cholera epidemic in your area. You went to a well, you took some water out, you put it in 5 test tubes and calculated that what amount of bleaching powder is required to be poured in that well. That calculation is done with the help of Horrocks apparatus. Okay, then you put some amount of bleaching powder in the well based on that calculation. After putting that amount of chlorine in that well, you waited for 1 hour, and after 1 hour you took out the chlorine and calculated the amount of free chlorine in the water with the help of orthotolidine arsenide test. And if the free chlorine is about 0.5 milliequivalent after 1 hour, then you consider that this well water is safe for drinking. If it is less than 0.5 after 1 hour of contact, then you say that this well water is not fit for drinking. We need to add more bleaching powder to it. Clear? So this is the whole concept behind decontamination of water. Okay? And don't think that cholera has been eradicated from India. Still there are various episodes of cholera in various tribal areas, like one where I went to in Chhattisgarh. But the point is, all the district hospitals and PSC does not have the testing kit, the VR kit, Venkatraman kit, required to test for cholera, required to test for presence of cholera. So they don't report it to higher authority. And hence the cases of cholera goes unrecorded. Now, let's move to another question. That is, hardness of water is not due to which of the following ion? Hardness of water means ability of water to form lather with soap, to form lather means froth with soap. Hard water have no ability to produce. Hard water will have decreased ability to produce lather with soap. Why? Because in hard water there are either bicarbonate or sulfonate which react with soap and they do not lead the froth formation to happen. So hardness of water is because of bicarbonate, sulfates. So, and these classify hardness of water into two types. One is temporary hardness, other is permanent hardness. Okay. So temporary hardness, it means that hardness which can go out by boiling, hardness which can be removed by boiling, hardness which can be removed by boiling. And this temporary hardness is because of sodium bicarbonate or magnesium bicarbonate or calcium bicarbonate, mainly because of magnesium and calcium bicarbonate. Okay, so bicarbonates is responsible for temporary hardness. Okay, the permanent hardness is because of sulfates and chlorides of magnesium and calcium, that is calcium sulfate, magnesium sulfate, calcium chloride or magnesium chloride. Okay, so if there are sulfates and chloride, then they sulfate and chloride, they do not go away just by boiling the water. That means it is permanent, and that means it is permanent hardness. Okay, but temporary hardness, the hardness can go off by boiling. The other method to remove temporary hardness, the second method, is by adding sodium carbonate. And the other method to remove permanent hardness is by permutate exchange method. What is permutate exchange method? Permutate is a polymer of sodium, calcium, silica. Okay, and in this polymer, this sodium will be replaced with calcium and magnesium, and hence this permutate exchange method can remove permanent hardness, along with temporary hardness. But temporary hardness can easily be removed by boiling or by adding sodium carbonate. Okay, so coming back to the question, there are two bicarbonates, they both are responsible for temporary hardness, and calcium sulfate is responsible for permanent hardness. But calcium carbonate does not lead to any hardness, so the correct answer is calcium carbonate. In fact, calcium carbonate is formed as a precipitate after boiling. Suppose this is calcium bicarbonate. After boiling, it leads to formation of calcium carbonate plus H2O plus CO2. So this calcium carbonate is formed as a precipitate after boiling. And it is not responsible for hardness of water. Okay, what it leads to? It leads to formation of a scale in the bottom of the tank in which you are boiling the water. There will be a white deposit in the bottom. That will be because of calcium carbonate. Okay. Now when will you call water as unfit for drinking. Hardness of water is defined as fit for drinking. If you have to find out whether the water is fit for drinking or not fit for drinking, you divide water into 4 categories. Okay. One is between less than 50 or less than 1 milli equivalent. This is known as soft water or good for drinking. Then if you have the concentration of this 1 milli equivalent, it represents concentration of calcium chloride. Okay? So if the hardness is between 50 to 150, it is some hardness but fit for drinking. Some hardness but fit for drinking. Fit for drinking. If the hardness is between 150 to 300, it will be hard water and not fit for drinking. If it is more than 300, it will be severely hard water and totally unfit for drinking. So this division is based on concentration of calcium chloride, calcium carbonate equivalent. And if it is between 50 to 150, less than 150, then it is drinkable. If it is more than 150, it is hard water. For hard water, it should be more than 150. So the objective question that they ask is, if the hardness of water is between 150 to 300, it will be classified as hard water. When will you call water as unfit for drinking? When the concentration is calcium carbonate is more than 150 milli equivalent. Or in milli equivalent, it can be 1 to 3 or 3 to 6 and more than 6. Okay. This is the concentration in part per million, 50 part per million, and this is the concentration in milli equivalent. Okay. Now moving on to next question. Which of the following is not a direct mode of transmission? This was a simple question. Since in droplet infection we sneeze and the droplet directly reach to other person, so it's a direct method of transmission. In air again we cough or sneeze and the molecule reaches to other person, like in influenza. In skin contact again there is direct transmission. A direct method means no intermediate agent. How the soil transmit infection? What happen is the infective agent laid their feces having cyst in the soil, and if someone touches anything which is contaminated with that soil and eat that thing, then the cyst goes to the intestine and lead to that infection. So this is an indirect method, because in soil an intermediate agent is required. So the answer to this question is soil, because it is an indirect method of transmission. Now coming on to the next question. A child of 6 kg body weight was brought to you with complaint of loose stool. Child is restless but drinking water. He have sunken eyes and skin pinch test, so going back within 2 seconds. What dose of ORS will you give to the child? To solve this question, first we will have to know how to classify child into no dehydration, some dehydration and severe dehydration. Then we have to know plan A, B and C, which we apply for all these 3 group of patients. Okay. So first know how we classify child into no dehydration, some dehydration and severe dehydration. For that, we look at 4 things. First is appearance. If the child is well and alert, he is no dehydration. If the child is restless, he has some dehydration. If the child is lethargic, unconscious, not responding to your twitching or not responding to a mother's call, he might be called as lethargic or unconscious. But you have to be careful. If the child is sleepy, he might again be unconscious. Now, If you look at eyes and it is sunken, it is some dehydration, very sunken, severe dehydration. You look for thirst. If the child is drink normally, then he is no dehydration. But if the child is drinking a lot, he is having some dehydration. But if the child is not drinking at all, then he might be having severe dehydration. If the skin pinch test is one which you do by twitching the skin over the abdomen. What you do, you take some amount of a skin and you make a pinch over the abdominal skin and you leave the skin after that. If it goes back slowly, it is some dehydration. If it goes back very slowly, and you can appreciate the wrinkle forms during the twitching. If there is wrinkle formation, then it is mostly indicating severe dehydration. So in no dehydration we apply plan A, in some dehydration we apply plan B, and in severe dehydration we apply plan C. What is plan A? Plan A is to give 100 ml of ORS per episode of loose stool. For every one episode of loose stool, you give 100 ml of ORS, and in adult, give as much of ORS as the patient can drink. No upper limit. जितना पीना चाहे वो पीने देना है. Okay? Then what is plan B? In plan B, what you will do is, you will give 75 ml per hour. 75 ml per hour of ORS for 4 hours. And what will you do after 4 hours? Again after 4 hours you will do the skin pinch test. You will look at appearance. You will look at thirst of child, and you will classify the child that now he needs treatment according to plan A, plan B or plan C. Okay. But what is in plan C? In plan C you have two age group. One is age less than 1 year. One is age more than 1 year. In both of this age group, first you will give 30 ml per hour, and then 70 ml, 30 ml and 70 ml. And here again in this you will give 30 ml and 70 ml. The difference is, here you will give 30 ml in 1 hour. Okay, and 70 ml in 5 hours. If the child is more than 1 year, then you will give 30 ml in half hour and 70 ml in 2.5 hours. That is, here the total duration is 6 hours. For less than 1 year, you will give fluid slowly. That's why you take 6 hours. But if the child is more than 1 year, you can give fluid rapidly, and hence you take only 3 hours. Okay. So in this case, the child is having two symptoms. One is child is restless. The second is child has sunken eye. The skin pinch goes back within 2 seconds. So it's not appreciable what it is. But since he is having two symptoms, restless and sunken eye, both belong to some dehydration. Restless, sunken eye. Moreover, the thing is, child is restless but drinking water. Here you can see he is restless and drinking water. So he drinks eagerly. So again this is a symptom of some dehydration. So according to some dehydration plan, you will give this 75 ml per kg body weight. Per kg body weight of ORS in 4 hours. Of ORS in 4 hours. Okay. 30 ml per kg, 70 ml per kg in duration that is given. So here the weight of the child is 6 kg. Total amount of fluid that is required is 6 kg into 75 ml. That will be equal to 450 ml in 4 hours. Okay, this is the fluid that you will give to this case. and hence the answer is 450 ml in 4 hours. Clear? Okay, let's move to next question. Next question is RDA. RDA is recommended dietary allowance, which is required for maintaining a healthy status of the body. So recommended dietary allowance of iodine in pregnant female is, okay, let's look at the table to understand this. For pregnant female, calcium required is 1300 milligram, okay. Sodium required is not never asked. Iron required is 27 milligram, and iodine required is 220 microgram. When it comes to lactating, the iodine requirement increases to 290, iron requirement decreases to 10, and calcium requirement almost remain the same. So here these are the 3 points which you need to remember. 27 milligram iron, 220 microgram iodine, and 1300 milligram of calcium. Okay, so in this question the RDA of iodine for pregnant female will be 220 milligram. If it would not be pregnant, if lactating woman would have been in the question, lactating female, it would have been 290, है ना, 290 mcg. mcg is microgram. Okay, 220 for pregnant and 290 for lactating. Moreover, 27 milligram of iron and 1.3 gram of calcium is required to maintain normal healthy status in a pregnant female. Moving to next question, minimum time interval between administration of 2 live vaccines. The answer is 4 weeks. Okay, as you all know that at the age of 6 week, 10 week and 14 week, 3 doses of injection are given, and there is a gap of 4 week in all those 3. Also, why we take this gap of 4 week? Because if we give 2 live vaccine within this 4 week duration, suppose one at today and one after 1 week, then this live vaccine will not get the time to develop the active immunity, and the live vaccine may cross react with each other. Okay, so we take a minimum interval of 4 weeks, and in this table I have shown you the universal immunization program of the recent universal immunization program opted in India. Okay, so you should remember all of these vaccine when they are given, and do go back and remember this chart. Okay, in this chart there is 2 things which you should notice. First is IPV is given only at 14 week of age. 13 is the second thing is rotavirus is given along with pentavalent vaccine and OPV at 16 and 14 week. The third thing is DPT second booster is given at 5 to 6 year of age, and not DT. Previously we used to give DT booster, but now we give DPT. Why? Because previously that pertussis strain can lead to neurological complication, but now we use a pertussis strain that is less dangerous, and hence we can use DPT in the second booster rather than DT booster which we used to give previously. Okay, so these are the 3 things. IPV is given only after giving OPV3 at 14 week of age, rotavirus is given at 16 and 14, and then DPT booster is given at 5 to 6 year of age, not DT booster. Okay, one more thing which you should know, that Japanese encephalitis vaccine is also given at 16 to 24 month of age. Okay, along with measles second booster. This is a latest addition. Measles second dose is also given now in the form of MMR at 16 to 24 month of age. Okay, now Mission Indradhanush does not include vaccine. The answer is meningococcal. Mission Indradhanush have vaccines for measles, polio, pertussis, tetanus, TB, diphtheria and hepatitis B. That's why it is known as Mission Indradhanush. Indradhanush means rainbow, and rainbow consists of 7 colors. So there are 7 diseases from which Mission Indradhanush protect you. 1, 2, 3, 4, 5, 6 and 7 disease. So what all are the vaccines which we give in it? One is DPT, then BCG, then OPV, then hepatitis B. So 3 plus 1, 4, 5, 6. One more is measles. So these are the total 7 color, that is 7 disease. 7 disease protection. Okay. So Mission Indradhanush mainly focus on all the children that are found in either in bricklins area, that bricklins means ईटा भट्टी पे काम करने वाले मजदूरों के बच्चे, then the children who are found in railways or in bus stops or during traveling, which are usually left over, they all are covered under Mission Indradhanush specifically. And hence it has helped in improving the vaccination status in India. Okay. Now, the next question is pasteurization of milk is done at. The correct answer is 63 degrees Celsius for 30 minutes. Why? Because only 63 degrees Celsius is done at 30 minutes. Rest all we use only second. Only second. And 72 degrees Celsius we hit for 15 seconds, not for 20 minutes. If 72 degrees Celsius for 20 minutes is wrong, it would have been 15 seconds. Then it would have been correct. Okay. So the correct answer is 63 for 30 minutes. What is this HTST? That is high temperature sterilization technique. High temperature sterilization technique. Okay. And batch pasteurization is 63 degrees Celsius for 30 minutes. Okay. Clear? In high temperature method, we held at high temperature for a short time. Okay. And 72 degrees Celsius is done for 15 seconds, 133 for 1 second. Okay. Now, this is a new question which was never asked before. Let's look at this question carefully. A new test was introduced. It diagnosed 90 patients out of 1000 with the disease. When gold standard test was applied, it measured 1000 patients out of 100. It diagnosed 100 patients out of 1000. New test diagnosed only 90 and old test diagnosed 100 patients. This old or gold standard test will also be known as control. Why? Why control? Because we already know about it, and this newly diagnosed case is the treatment. This is the new thing which is done. This is the treatment part. Why? Because it is new thing, so it is the treatment, and because we already have a gold standard, so it was the control. So the question which they ask is to find the efficacy of the new drug. For that we need to know the formula for efficacy. The formula for efficacy is control minus treatment into 100 divided by control. C minus T into 100 by C. As I told you, the control in this case was the gold standard, so it was 100 minus T yani treatment, it is 90 divided by C yani control yani 100 into 100. This will be the efficacy. So the formula for efficacy is equal to control. कंट्रोल को हम लोग और क्या कह सकते हैं? गोल्ड स्टैंडर्ड माइनस ट्रीटमेंट. ट्रीटमेंट का क्या हम लोग और वर्ड यूज कर सकते हैं? न्यू टेस्ट. ओके. डिवाइडेड बाय ट्रीटमेंट डिवाइडेड बाय कंट्रोल into 100. This is the formula for efficacy. Control minus treatment by control, and hence it comes out to be control is 100, so 100 minus 90 by 100, and hence the formula is answer is C. Now, okay. Now efficacy is calculated by this formula, and if vaccine effectiveness is asked, then it may be asked in other exams that vaccine effectiveness, then incidence in unvaccinated population by incidence in vaccinated divided by incidence in unvaccinated. So these two are common, unvaccinated minus incidence in vaccinated. then we will be able to know vaccine effectiveness. Okay. Now let's move to another question. Kala azar. Kala azar is also known as leishmaniasis. Leishmaniasis caused by Leishmania donovani, transmitted by sand fly. I already told you about this thing in our very second question. Okay. So Kala Azar endemic states are all except. For this question, you can look at this map. In this map, you can see the green area indicate those states which are endemic for Kala Azar. What do you mean by endemic? Endemic means states or area which have the disease in a regular manner. That means every year cases keeps on coming in that area. That is endemic for that disease. So in India, this part is Assam. This is Assam. And in Assam, Kala Azar is not present. But it is present in Jharkhand, it is present in UP, it is present in West Bengal, and it is mainly present in Bihar. Okay. So these are the 4 states which is endemic for Kala Azar, not Assam. So the answer for this question will be Assam, because Bihar, UP, West Bengal and Jharkhand was there. Okay. Now if the same question comes, but in spite of Kala Azar, they ask you about Japanese encephalitis. That the question is, for Japanese encephalitis, endemic states are all except. Endemic states are all except. And the answer would have been Jharkhand. Why? Let's look at the graph of India representing endemic states for Japanese encephalitis. This is graph representing Japanese encephalitis, the killer disease. The disease which recently killed 600 children in just 1 week in Gorakhpur BRD College Hospital. So it is endemic in UP, in Assam, in West Bengal and in Bihar, but not in Jharkhand. Okay. And that death is going to happen again this year as well. Okay, because all the CHC and PHCs are not functional in those areas. So all the patients are referred to just one hospital, which is again compromised because of poor allocation from Government of India. So the endemic states for Japanese encephalitis is Uttar Pradesh, Assam, West Bengal and Bihar. The endemic state for Kala Azar is Uttar Pradesh, West Bengal, Bihar and Jharkhand. Okay. Now, correct statement about Factory Act. Factory Act, first option is child working below age 14 cannot do dangerous work. Factory Act was established in 1948. It clearly says the child working age 14 cannot do any work. They cannot be implied. So dangerous work is not an option at all. So the option 1 and 2 are left because child working age below can do some work is also eliminated. Now, there is a provision that children working between age 15 to 18 can work in a factory, but they cannot do dangerous work. The correct option is D. But here they can work. They need a certificate from a surgeon, certificate from a doctor, which says that they are fit to work, which say that they are fit to work. Fit to work. And then only they are sent for work. Okay. So the correct answer is child working between age 15 to 18 cannot do dangerous work. They can do some work if they get the certificate from a doctor, but they cannot do dangerous work. Okay. Now, next question is, Which of the following is advantage of parametric test over non-parametric test? Option A is correct, that regression can be determined by parametric test, but we are not able to get the other options. But we need to know what is parametric test and what is non-parametric test. Okay, because this topic is very important and relevant for you. Why? Because in parametric test, you will have t-test, student t-test and ANOVA. And they frequently ask that what is the type of test which you will apply when you have to find difference between mean of, and that means they keep you asking that how will you decide that which test is to be applied in which situation. Okay. So what is a parametric test? Parametric test, it means it measures quantitative, it deals with only quantitative properties, quantitative variables. What are quantitative variables? Quantitative variable is also known as continuous variable. Example are, yes, weight, height, hemoglobin level, sugar level, BP. They are all example of quantitative variable. Why? Quantitative means the variable which can be quantified, which can be measured. See, weight can be measured, height can be measured, hemoglobin level can be measured, and sugar level can be measured. And there can be decimal point as well. Weight can be 80.2, 80.3 kg. It can be anything. Height can be 5 foot 6 inch, 5 foot 6.5 inch, anything. So these are all quantitative variable in which we measure parametric test. Okay, which we perform parametric test. So what is non-parametric test? Non-parametric test are those tests which measure qualitative variable. Qualitative variable. What is qualitative variable? Qualitative variable is like underweight and overweight. This will be a quality. Like anemic and non-anemic. Okay, like diabetic and non-diabetic. This type of two grouping or two or more than two grouping, like we can classify anemia as mild anemia, moderate anemia and severe anemia. So these are all the quality, you can see. So this is qualitative variable. Why? Because they tell about quality. And underweight and overweight, anemia, non-anemia, diabetic, non-diabetic, these are quality of a person, of a particular patient or a person. So in all these cases where we have to use qualitative variable, we measure it with the help of non-parametric test. But if you have to measure quantitative variable, we measure it parametric test. Okay. Now look at this two type of test. In parametric test, the main test which we use is paired t-test, student t-test and ANOVA. Paired t-test. In paired t-test, the thing is there is only one subject, one group of subject. ठीक है, and what we measure? we measure pre and post intervention mean values. For example, let us understand it with example. If in a group of pregnant female, you give IFA for 6 months, along with breakfast, early morning healthy breakfast, and after 6 months you measured mean HB of pregnant female, IFA for 6 months, then again you measured mean hemoglobin after 6 months. So here the test which you will apply is paired t-test. Why? Because there is just one group pregnant female, and this is pre-test data, and this is post-test data. So here you will call it as paired t-test. Okay, clear? Now moving on to unpaired t-test. Unpaired t-test is also known as student t-test. Okay, student t-test, so the same. Student t-test and unpaired t-test is applied for more than one group. And we compared more than one group, mean value is compared. Okay, for example, in this example, unpaired t-test, you will take one group of pregnant female and one group of adolescent female belonging to age group 10 to 19. Okay, in both of this age group you give 6 month IFA. Okay, IFA, and in both of these group you measured mean hemoglobin after intervention and mean hemoglobin after intervention, and you want to compare whether mean hemoglobin increases more in pregnant female or it increases more in adolescent female. Then the type of test which you will apply it in unpaired t-test, because there is more than one group, two group. Okay, or two group. Now the third type of test is ANOVA. ANOVA is known as analysis of variance. And analysis of variance is done, it is again a type of parametric test. So we measure only quantitative variable. I already told you that parametric test measure only quantitative variable. So in analysis of variance you have more than two group, and mean is compared. इसका एग्जाम्पल क्या लेंगे हम लोग? In the same example, take three group as pregnant female, one group as pregnant female, other as adolescent girl, and the third one as lactating female. Three groups. In all the three group, you give 6 month IFA, and you compare mean hemoglobin of each group. Then since there are more than two group, then it will be example of ANOVA, analysis of variance. Okay, so these three are example of parametric test. Okay, these are parametric test. This is parametric test, and again this is parametric test. Now, what is an example of non-parametric test? Example of non-parametric test is chi-square test. Okay, You all have heard about it, chi-square test. ठीक है? I told you that non-parametric test is applied on qualitative variable. Non-parametric is applied on qualitative variable. Qualitative variable. Okay? And chi-square test is similar to unpaired t-test or student t-test. Student t-test is the unpaired t-test. Okay, it is the same name. That means in chi-square test you will have two groups, but what you will measure? You won't measure the mean. The result will be measured in terms of median or proportion or percentage. For example, in the same example, if you have two group, one of pregnant female again and one of adolescent girl, in both the group you measured number of anemic female and anemic girl. Okay, and in both the group you give 6 month IFA. Okay, after giving 6 months of IFA you measure percentage or proportion of female which became non-anemic after treatment. You are getting my point? What you are doing here is you are measuring the things in terms of percentage and proportion and not in terms of mean value. So the only difference between non-parametric and parametric test up to now is that non-parametric measure qualitative variable and it measures in terms of percentage or proportion or median. ठीक है? And quantitative test is known as parametric test. They measured in terms of mean increase or mean decrease in hemoglobin level. Okay? These are some of the differences. Now, in your objective questions, many a time they give you example in which they write that which test will you apply. So, if in the question they have given you mean value, then you won't apply chi-square test. But if they have given you percentage or proportion, then you will apply chi-square test. Okay? There are some more difference between parametric and non-parametric test. Parametric test and non-parametric test. Parametric test. One is, in parametric test, you have normal distribution. Okay? Normal distribution means distribution like this. In non-parametric test, you have non-normal distribution. Okay? Then the other point is, in parametric test, you make assumptions. In non-parametric test, you don't make much assumptions. ठीक है? You can make assumptions. Assumptions like, for example, you can assume that the data is normally distributed. Okay? Almost no assumptions. Almost no assumptions. The correlation coefficient in parametric test is Pearson correlation coefficient. Pearson correlation coefficient. And the coefficient. And in non-parametric test, you have Spearman correlation coefficient. Okay? The other thing is its example include chi-square test, and its example include t-test, which can again be paired or unpaired. Unpaired will be like chi-square test. Paired test will be equivalent to sign test. And then you will have ANOVA. Okay, which will be equivalent to Kruskal-Wallis test. Kruskal-Wallis test. So these are some of the differences. And regression can be done easily in parametric test. Regression can be done easily by parametric test. So that was one of the option, but since I am not able to get all the 4 options, I cannot conclude that that was the only correct option, but the one was correct. Now, that is the second question, which is linked with calculating or knowing the basics about p-value. The question says that a new antihypertensive drug is tested against an existing gold standard drug and p-value is 0.04. What does it implies? So we know one thing about p-value, that if p-value is less than 0.05, study results may be significant. That is all we know. Okay, that is all we know. That means if p-value is 0.05, we reject the null hypothesis. If p-value is more than 0.05, we do not reject the null hypothesis. And we do not try to understand the concept behind p-value after knowing about this. But let me try to explain to you what does p-value mean. Okay. But to know about concepts of p-value, we have to understand about null hypothesis, alpha error and beta error. Please be patient and listen to what I am saying very carefully. Okay. First point is null hypothesis. What is null hypothesis? Suppose before starting any study, we assume that there is no difference between new study and the previous study done. This is null hypothesis. Why we consider null hypothesis? Because if at the time of starting the study, if we assume that our study is going to be better, then our result will be manipulated, because already we are convinced that our study will produce result. This is a wrong practice. So null hypothesis prevent this wrong practice. What is null hypothesis? Null hypothesis says that 2 tests or intervention results are similar. That is, new intervention is equal to previous intervention. This is null hypothesis. Okay. Suppose I did 2 experiments. In experiment 1, I give amphetamine tablet. What is amphetamine tablet? Amphetamine tablet is also given to driver, not given, but is also taken by driver and students to remain awake at night while studying. Okay, this amphetamine drug is used for treatment of ADHD disorder and attention deficit hyperactive disorder. So amphetamine is an sleep removing drug, and I give amphetamine drug to your batch preparing for a PG entrance examination, to one batch, to batch A, and placebo कह लो या बिकासूल टैबलेट कह लो to batch B. Bicasul is not placebo. Bicasul contain multivitamin. Suppose I give just simple sugar coated tablet which is not having any effect, then that is placebo. Amphetamine drug to batch A and placebo to batch B for 6 months. ठीक है? To know whether their performance improved by taking amphetamine tablet or not. Okay? After 6 months, batch A results were similar to batch B. Okay? But researcher manipulated the result. In this example, what I did is I manipulated the result. I said that my result is better. So I said that my result is better, but I or researcher, what I said? What I did, researcher manipulated the result. Manipulated the result. And said at the end of a study, researcher said that amphetamine was useful. Amphetamine was useful. ठीक है? So actually batch A result was similar to batch B result. So this was the fact. The fact was, or the truth was that batch A and batch B were having similar result after taking amphetamine drug. But at the end of study, researchers said that amphetamine was useful. That batch A performed better. But that was not the case. Okay? So this method of manipulating the result, of saying that my experiment is better, this is known as alpha error. Alpha error means manipulating the result and saying that at the end of a study amphetamine is useful, then that batch A performed better than batch B. Okay, this is type 1 error, or this is alpha error. Now, in the second experiment or experiment 2, what I did, I gave researcher gave nutritious breakfast plus IFA tablet to batch A and placebo to batch B. Okay, placebo to batch B. Then after 6 months, batch A performance improved. okay, over batch B. But researcher said that both intervention are similar, that both batch A and batch B result are similar. Okay, if both batch A batch B result are similar, then it means कि null hypothesis is true, because null hypothesis says that both batch A and batch B will have same result, that both the intervention is similar. This was the null hypothesis which we decided before starting the study. So this type of error, that even if you are getting significant result and you are saying that your result is not significant, this is type 2 error, this is beta error or type 2 error. Okay, are you getting my point? In type 1 error, the truth was both the result was similar. The truth was that null hypothesis was true. Why true? Because both giving amphetamine and not giving amphetamine in experiment 1 was leading to similar result. So since it is leading to similar result, it means null hypothesis was true. But what the researcher said कि my experiment of giving amphetamine was better than giving placebo. That means researcher by himself tried to fool the audience and he said that his experiment is better. This is alpha error. Okay, this is alpha error. In Hindi you can say that this experiment type 1 this researcher is chalu, है ना? So because he tried to manipulate the effects, and even if the null hypothesis was true, he rejected it. This is type 1 error. Okay, in type 2, actually by giving breakfast and IFA tablet, result of batch A improved, but the researcher was not able to capture that effect, and researcher said that my experiment is similar to giving placebo. That means in spite of getting significant result, researcher neglected it. It is a type of type 2 error, beta error, and in Hindi you can say it बेवकूफ, because he was getting a significant result but he rejected it. He accepted the null hypothesis. He said that my result is similar to the placebo, is similar to giving placebo. This is type 2 error. Are you getting my point? Let's get it more clarified with this table. See, in this table, in the upper right hand side, I have written the truth. The truth, first the null hypothesis is true. What does it mean? Null hypothesis is true means two experiments or the intervention is similar to the previous one. The experiment is similar to the previous one. This means null hypothesis is true. Now, in the second column, you are seeing that null hypothesis is not true. See, the upper hand side writes the truth. The truth, null hypothesis is true. Null hypothesis is true का मतलब क्या होता है कि both the experiments are similar. This was null hypothesis. So, if I have said that both the if in reality if the truth is both the experiment is true, but I rejected null hypothesis, I said that my experiment is better than the previous experiment, then it will be a type of type 1 error. See, reject null hypothesis का मतलब I said amphetamine is better than placebo. This is means reject null hypothesis, because null hypothesis says that both amphetamine and placebo are same, and that was the truth. The truth was amphetamine was not making any improvement, है ना? That was the truth. That means the truth was that both amphetamine and placebo were leading to similar result. That was the truth. But what I did, I rejected the null hypothesis. I acted as Chalu, and this led to type 1 error. And this type 1 error is almost equivalent to p-value. It is also says that overreacting, or it can be also said as Chalu. Why Chalu? Because the study was not significant, but I manipulated, and I said that my results are significant. I said amphetamine is better than placebo, but in reality both are same. In reality, null hypothesis is true. This is type 1 error. Now, what is type 2 error? Type 2 error is said when the null hypothesis is not true. That means giving breakfast improves result. But what I said I accepted null hypothesis. I said that my giving breakfast was also similar to giving placebo. I accepted null hypothesis and I acted as a बेवकूफ, or it is also can be called as underreacting. I did an underreacting. This is type 2 error. Okay. So as you can see, a p-value means an type of alpha error. It's a type of alpha error. You can say that p-value is ability to reject a null hypothesis when in truth null hypothesis was correct. That is, p-value is ability to say that amphetamine is better than placebo, when in reality it is similar to placebo. It is means amphetamine is similar to placebo. Amphetamine is similar to placebo. Okay. So p-value means how much we are fabricating the result. What is the chance that we may say that an insignificant result is significant? What is the chance that we reject a null hypothesis when in truth null hypothesis is correct? So it should be minimum. We should be minimum Chalu. Then only our study will be read as significant. We should be doing minimum alpha error. So this alpha error is one thing which we decide. Alpha error is decided before starting the study. And then at the end of a study, p-value is calculated. Okay? By applying t-test, chi-square test or student t-test, which I said, we calculate the p-value. And if p-value is more than alpha error, it means we done more mistakes than we have claimed before starting the study. Okay? Okay? And then if p value comes out to be more than alpha value, then study result is rejected. Kyun? Because we have done more mistake than expected. So study result is rejected. Similarly, if p value is more than 0.05, again it means that we done more mistakes than we have claimed before starting the study. It again means that study result is rejected. Or it in another word, if study result is rejected, it means null hypothesis it means that study result, if the study result is rejected, it means that we cannot conclusively say that whether our drug is better than the existing drug or they both have same result. We cannot say it conclusively. Okay? So let's revise the concept once more so that we can understand it completely. Before starting any study, we first put a null hypothesis. In the null hypothesis, we say that two tests or intervention are similar. This is null hypothesis. We say giving amphetamine and giving placebo are similar. There is no difference in the two groups in which we give amphetamine and placebo. Then we did this study, and after doing the study, what we did is we find that amphetamine and placebo are similar. That means null hypothesis was true. But since I was a chalu researcher, since I want to prove that my drug is better, I said that amphetamine is better than placebo. This is type 1 error. This is p-value. If I am doing this mistake of saying that my study result is significant, even when it is not significant, it is type 1 error. P-value is ability to reject null hypothesis when actually it is true. Okay? Then, whether or not a result is significant, it depends on two things. One is, if the p-value that is calculated at the end of a study is more than 0.05, then the study results is rejected. The second thing, if p-value is more than alpha error, then again the study result is rejected. And the third thing is regarding confidence interval. So these three things conclusively make you understand that whether the study result are worth accepting or cannot be accepted. Okay? It means that you cannot say based on p-value that whether the new drug is effective or not effective, because you need three things. One is p-value should be less than 0.05. Second is p-value should be less than alpha. Third is confidence interval should be narrow and it should not include 1. Should be narrow and it should not include 1. Then only you can say that study results are significant. In this case, p-value is less than 0.05, but the other two conditions are not fulfilled. If these are not fulfilled, you cannot say that my drug is more effective than the existing drug. If all the three conditions would have been fulfilled, then new drug is more effective than older drug. But if it is not, if all the three conditions are not given in the question, then we cannot say anything from the given information, because we don't have alpha value and we don't have confidence interval. Okay? Try to go through this experiment thing which I have written and remove your confusion which you will get while solving it. Now I have the last two questions based on image based question. One is from dermatology, that is to identify the causative organism for this disease. These are warts. These are warts. And warts are found in two diseases. One is HPV. HPV is human papilloma virus, very correct. Papilloma virus. And they lead to formation of what? Then how will HSV, CMV and herpes zoster will represent themselves? Let's look at other slide for that. This is a slide showing hand and foot disease found in milkman and leather industry worker. Okay, this lesion, these are characteristic of CMV infection, that is cytomegalovirus infection. Cytomegalovirus infection. And this infection, cytomegalovirus infection, are found in immunocompromised individual, HIV patient, or patient taking or immunocompromised, or patient taking anti-cancer drug, or patients on steroids. So immunocompromised patient. Okay, this is CMV infection, cytomegalovirus infection. Okay, now look at other slides. These are herpes simplex HSV type 1, affecting lip areas in and around lip. This is herpes simplex type 2, which affect inguinal region of both male and female. In both herpes simplex, both type of herpes simplex, you will find fluid-filled vesicles that are painful. They are present in both. Okay. Now, similar to this HSV, there is herpes zoster. Again, there are fluid-filled vesicles. But one thing which is characteristic of HSV is that it affects only one dermatome. What is a dermatome? Dermatome is that part of skin which is supplied by single nerve. That means singles or herpes zoster will occur only in one nerve distribution area, as you can see here, as you can see here, as you can see here. So if it would have been a herpes simplex, like in the previous, herpes simplex 1 will be present around lip, herpes simplex 2 will be present around inguinal area. Herpes zoster can be found anywhere, but everywhere it affect only one dermatome. Okay, present in one dermatome only, just one dermatome. These all, either it is present in two area, but both of these area are supplied by single nerve. So it affect part of a skin that is supplied by one nerve. Again, it is supplied by one nerve. Okay. If it would have been spread all over, like if the lesion is also here, the lesion is also in this whole area, it cannot be herpes zoster. Okay. Now this is, what is this is? This is known as hairy cell leukoplakia. It is caused by Epstein-Barr virus. Okay, and hairy cell Epstein-Barr virus causes one more thing, that is Burkitt's lymphoma. And Epstein-Barr virus also affect generally immunocompromised HIV patients and immunocompromised patient. they are affected by Epstein-Barr virus, and hairy cell leukoplakia will look like this. Okay. Now, moving on to next question. So the answer to this question was human papilloma virus. Okay, and rest all the option you are now you are familiar with the type of lesion that will be present in human herpes simplex virus or cytomegalovirus or herpes zoster virus. Okay. Now, in this question, a man presented with complaint of pain and tenderness, history of trauma 2 years back. Then they give you this X-ray and want to know what this X-ray is suggestive of. See, in this X-ray, you will be able to appreciate this darker region here. This darker region is present in medullary region of bone. Medullary region, है ना? In medullary region. Not in the peripheral region. Na? This darker region is present in the central part. This central part is having this darker region. So, and the trauma is of 2 years back. So, this X-ray is suggestive of chronic osteomyelitis. Now, you may ask that why it is not suggestive of TB, because TB might also look like this. For that, let's go through all the options and X-ray that may appear in all the options one by one. First, this is the diagram of suggestive of, rewrite, osteosarcoma. Osteosarcoma. What it is, this part is suggestive. This part is suggestive of sunburst appearance. And there is this characteristic angle which is also present in osteosarcoma. One thing about osteosarcoma is that it is present at metaphysis. Okay. So if this X-ray come, it is of osteosarcoma. Then this X-ray, in this X-ray, you are finding onion pill appearance in the periosteal region. Periosteal region just in the outer part. This is the onion pill appearance, and this is characteristic of Ewing sarcoma. Onion pill appearance present at this Ewing sarcoma. You can see here also there are this lining in this X-ray as well. There are some lining in the periosteal region, and it affects this region. This region is the diphysis. So diphysis is the middle part, metaphysis is this part, and epiphysis is this part. So diphyseal region is affected in Ewing sarcoma, and it is having onion pill appearance. Whereas metaphysis is affected in osteosarcoma, it has sunburst appearance. Clear? Now let's look at osteoarthritis. See, there is some joint space. There is joint space. But in this, the joint space is lost, no joint space. Moreover, this part adjacent to this joint space is dense white. This dense whitening is known as subchondral sclerosis. So joint space narrowing and subchondral sclerosis is characteristic of osteoarthritis of hip joint. Okay. Now look at this tuberculosis of femur. For the tuberculosis, it has to be fulfilling two things. One, first it should be well-defined bone, well-defined. Second, it should be at metaphysis. Well-defined lesion at metaphysis. Okay. So now you are sure that this is of chronic osteomyelitis. Why not of TB? Because in TB it would have been well-defined and present at metaphysis only. But chronic osteomyelitis can present at any site and it need not to be well defined. Now let's look at difference between chronic and acute osteomyelitis. In chronic osteomyelitis, you will find this, a remaining part of bone which is known as sequestrum. Okay, and this is suggestive of acute osteomyelitis. Only the periosteal region is affected. Okay. This is suggestive of chronic osteomyelitis. Now again, it is not well defined. You can see not well defined, but if it would have been TB, it would have been a well defined lesion. Okay. So that will end my discussion on objective questions regarding PSM that have been come over. I hope that you also revise objective questions in your PSM objective book to get a full command over your PSM question that may come in subsequent examination. And thank you very much for listening. Okay.